Hi, and welcome to the show. Subscribe at kevinmd.com/podcast to get CME for this episode by clicking on the CME link in the show notes. Today, we welcome back Bayo Curry-Winchell. She's a family physician, and today's Kevin MD article is titled, "I'm a Doctor and I Almost Died During Childbirth." Bayo, welcome back to the show.
Thank you for having me, Kevin. I'm so excited to be here.
Now, for those who want to listen to Bio's story, go to kevinmd.com/podcast. Upper right hand corner, there's a search bar. You can search for her last episode to hear her story. But today, let's jump right into your most recent Kevin MD article. It's titled, "I'm a Doctor and I Almost Died During Childbirth." How did your article come together?
So it was rooted in my lived experience. So we have often heard about Black women dying at the highest rates, either during pregnancy or shortly after. And so often what's socialized is it's about access and social economics. And I wanted to highlight that it goes beyond that. It is about systemic racism, it's about systemic practices that are impacting women of color and Black lives every day. And so by sharing my story as a physician, how I almost died, my hope was to really spark new conversation behind this topic and dig deeper into all of the elements that are a part of this really huge crises.
Now, before sharing your story, let's give a little bit more context. Do you have any data or numbers that can really illustrate that disparity?
Yes. So at this time, and it's been the same number for quite a bit of time, that Black women are dying at the highest rate. So three times more than white women. And so when you look at that data and you look at how robust our health care system is, that disparity, you have to ask yourself why. And the current climate or the current kind of go to is, oh, we need to really improve access, or it's a social economics issue. Well, there's more study and more data to support a recent article that shared that Black women of higher social economic status were dying in this category. So, those 2 points really reflect that it is much more than just an access problem, a social economic. We have to think of why this continues to happen. And I think the other part that is often not talked about is we know that the color of my skin, my race, is not biological. And so it's not a biological reason why I, as a Black woman, have a higher risk of dying. It has so many different areas. And so that's a little bit of, kind of data to support what I'm mentioning.
So please share with us your story.
So I had just given birth to my second child and I had come out of the OR. I had a C-section and I knew that I didn't feel the same way I did after my first one. And I was having a hard time concentrating. I was tired. And I know people are like, well, of course you were tired. That's a normal piece, but it just didn't feel the same. So I reached out to my nurse. I said, something doesn't feel right. Can you call my doctor? And she said, Bio, everything looks okay. Your vital signs look fine. What you are feeling is normal. So I sat with that for a little bit longer and then it started to get worse where I was having a hard time even just, speaking and
Mm.
just concentrating. And so I asked for my nurse to come back and I said the same thing. I said, this is getting worse. Please call my doctor. And she again just said, nope, everything that you're experiencing is normal. And I remember her saying, you look fine. And so she left the room and I told my husband, I said, please call my doctor.
Mm.
And so, of course, physician to physician, as most of us do, we have each other's phone numbers. And so my husband reached out to my doctor on my phone and
Mm.
said, something's wrong with Bio. Can you come back? And he did. And within minutes, I remember him just really taking in who I am. Most people who know me, I'm quite energetic all the time, even in different environments and situations. And he knew that I wasn't myself. And so he took me back to the OR. I was bleeding internally.
Wow.
I was transfused multiple units of blood. And I was hospitalized for 2 weeks. And so, as you know, Kevin, like my love and passion is health equity and health literacy. That has been a part of my fabric. And so to experience this and knowing the data, knowing my risk factors, and for this to happen as a physician, I just knew I was just like any other Black woman that is trying to give birth or deliver and have this almost happen to me. And so my hope is by sharing my story that I can help save other people and that we can look at this issue in a more broader aspect instead of just focusing on one or two issues that are a part of the problem, but definitely not the entire issue.
Now, as you reflected on this story and episode, did you have conversations with your physician and the medical team about what had happened?
I did. After all of this evolved, because I'm someone who leans into curiosity and asking questions because I think that's really important to be able to talk about an issue or something that happens. And as I when I was asking, the nurse and this is an important piece. It wasn't malice. It wasn't something as far as ill intent. She just couldn't see that what I was showcasing or what I was stating was pain. And I think that's an important piece that we forget, and that's unconscious bias. And it's something that we all have. And it's something, based on what we think how people look, behave, and talk. And it's not a bad thing. However, when it impacts the care that is delivered, we have to take note and find ways to acknowledge it and then find ways to change it so we don't impact lives. And so that's what was really the starting point. And I think that leaning into curiosity, sharing that part helped me be able to build this into something in hopes of sharing the story with as many people as I possibly can.
And when you share this story and other healthcare professionals are listening to you, either on the TEDx stage or on this podcast here, tell us what should have happened in an ideal world if this situation were to present itself again. Tell us what the ideal response should have been.
First, listening to me instead of thinking, I know what pain looks like, or I know what she's feeling, or she doesn't look like what I think needs to have help or that something's wrong. And I think as clinicians, we have to take the time to have some introspection and think about what do we feel or think that pain should look like on different people. And I think that is the jumping point, the starting point for us as clinicians. And so, what should have happened was when I said, I don't feel right, it shouldn't have just been thought of, well, she doesn't look like what something's wrong. Her
Mm.
vital signs look fine. Let me find out why she's stating that. What is concerning to her? And even though I don't see it and I don't understand it, let me go a little bit further and acknowledging it. And I think that could have just changed the entire trajectory. Calling my doctor, even if the first time you wanted to wait, you could have called and said, Bio just stated that she just wasn't feeling right. I just want to make you aware. And that could have made a huge difference in what happened.
One of the ways that we can address implicit bias you mentioned was we in healthcare, we need to reflect on ourselves. We need to ask ourselves sometimes hard and difficult questions. How can we do that? What kind of questions should we ask ourselves in order to combat this implicit bias? Because by definition, it's not something that we may even be aware of.
So, first, thinking about when you think of different people, different experiences, and the things that we've learned as clinicians, taking a step back and say, is this really about the individual? Is this really about that disease processes? Because we all know there's different labels that are associated with how people look, the color of their skin, and the identifiers of certain things such as drug seekers, pain seekers, and so forth. And think about how we get back to what we all love, which is delivering healthcare based on that individual. And then using all the amazing tools and skills that we have as doctors to help people. So the first part is acknowledging that it exists and being okay with that. And then, every day taking time to just make sure that your delivery or whatever you're going to put forward for that patient can you can remove those pieces of biases that may be happening thinking, oh, is this patient really in pain? And then ask yourself, why did I think that? What parts made me think of, oh, they must not be in pain? And I have to give an applause and a recognition to my physician who recognized this is not bio and took that forward. So I think those are the things that we can do. And I truly believe that's what he just thought to himself, this is not her. This is not who she is. I need to find out what's going on. I may not know what it is, but I need to find out why this is happening. And I think that's something each and every one of us can do is lean into curiosity, think about what's in front of us and make sure that we're not allowing our own thoughts to provide that care.
When you share this story, and I'm sure many people has heard the story, tell us some of the reaction that you received after they've heard that.
There was, a new perspective because people are always thinking, not always thinking, and I don't mean to say it that there was a new perspective that this does go beyond access. Because I've been in many conversations where people will say, yes, we need to expand access and have more centers. And that is true. We definitely need to have more birthing centers and so forth. But if those centers still are delivering care that is rooted in biases or race based practices, we can't move that needle. And so, that part, the other piece that is often a part of the conversation when I bring this up, when they hear my story, they'll say, well, I'm working on increasing payer access to Medicaid. And it's important I mention that because I'm sure everybody listening has heard that comment before with certain disease processes and certain things. And then I go back to, again, Kevin, that unconscious bias, that labeling and association that somebody must have a certain income status to have this disparity and inequity. And yes, that's a part of it. But when you hear my story, how I had the most access in the world, and privilege as a physician, and I almost died. It needs to you need to think about it from a new lens, and so that has allowed me to really bring forward a new thought process to it. And last but not least, I want to share, we talk about doulas and midwives and all of the important pieces that are a part of delivering a baby. And all of those things have to happen. But one powerful question that is often asked over and over, and I love giving this answer, I've been asked, are midwives the answer? Are doulas the answer? And I say they're a part of it. But if that clinician isn't listening to that patient, what makes you think they're going to listen to that doula or midwife? And that is all rooted in, again, that unconscious bias, that recognition.
Let me ask you from the patient perspective, because in your story, fortunately, you were able to directly call your physician, but not every patient can do that. So if patients don't feel like their healthcare team is listening to them, what kind of advice can you share with patients as to what they can do in that situation?
So the first thing is, and it sounds a little, of course, just a different thought process, is share with that team and state, I don't feel you're listening to me. Because again, that team may not have ill intent. they just didn't know that that you didn't feel heard. And so I think that part of just sharing how you feel can really make a difference and say, I don't feel like anyone's acknowledging what's happening to me. I don't feel like anyone is really taking into consideration what I'm asking or how I'm feeling. Now, if that if that request is still dismissed after you've leaned into curiosity, then taking it a step forward and finding, an advocacy team within that system and reach out to them and try to get a new team or help delivering your concerns. So, but the first step I think is asking and telling them, I don't feel like you're hearing me, because that can be, again, something that just allows the team to take a step back and say, I'm so sorry. I didn't know that you felt that way. So, those are two pieces that can really help you advocate for the best care.
We're talking to Bayo Curry-Winchell. She's a family physician, and her Kevin MD article is titled, I'm a Doctor and I Almost Died During Childbirth. Bayo, we end off with some take home messages that you want to share with the Kevin MD audience.
We are often privileged with all of this wonderful information. And so think about how you can use it in new ways. Think of anything that you've been doing for a long time as far as healthcare delivery, how you can take a step back and make sure it is the right way to do it. It is still rooted in delivering individual care, not based on association and labels. And involve yourself in uncomfortable conversations, because I think when that happens, your ability to really help people in new ways can foster and really do what you love to do. So I encourage everyone, please take a look at my new TEDx talk titled Do No Harm. It shares those uncomfortable conversations, those pieces that we as a healthcare team can really put forward and do what we love, which is delivering care.
Bayo, thank you so much for sharing your story, time, and insight. And thanks again for coming back on the show.
Thank you for having me.